Assalamu alaikum. My name is Dr. Irfan Yusuf. I'm a consultant neurosurgeon at Shaukat Khanum Memorial Cancer Hospital. I welcome you all to the 21st Shaukat Khanum Cancer Symposium. I'm the co-chair for this session of neurosurgery and neuro-oncology. My chair is Professor Dr. Kamran Hussain. He's on his way. So we have 4 speakers and we have all virtual talks. And on behalf of the organizing committee, I would like to thank all the speakers for their time and effort, put together excellent talks for this session. So without further delay, I'll request to kindly start the first talk, which is by Dr. Shahid Hamid. He's a radiation oncologist at the Arkansas Cancer Institute, Arkansas, USA. So kindly go ahead. Thank you.
Good morning, everybody. Thank you for inviting me to give a talk on role of radiotherapy in gliomas. This is our new cancer center, recently built in Pine Bluff, Arkansas. In 2016, WHO came up with new classification for diffuse glioma. Initially, it was just microscopic description, and it was graded as from 1 to 4, depending upon the morphology. But now they also introduced molecular classification depending upon IDH mutation and IP19Q co-deletion. Glioma survival is very variable depending upon the grade, anywhere from median survival of 10 years to 1.5 years. Like grade 2 oligo has 10 years median survival, whereas grade 4 GBM has 1.5 year median survival. Among oligo, if they are co-deleted 1p/19q, the survival is like 10 years. But however, if it is intact, then the median survival is only 3 years. So that's the importance of the molecular studies. Let's talk about GBM, which is the most common tumor and one of the most lethal tumor. This is a GBM histology, and as you can see, that there's a lot of necrosis there. Role of surgery is extremely important in gliomas. Rather, I would say it's the mainstay of glioma surgery. And again, the extent of resection is also extremely important. There were many studies came out, and they've shown very clearly that the more you resect, the better is the outcome. As you can see in this study, that the more the resection, better is the median survival. So you can see from 78% to 100%, and you can see the median survival goes from 12.5 to 16 months median overall survival. The role of radiotherapy was first introduced sometime in 1978 after this paper came out in the Journal of Neurosurgery in 1978 by Dr. Walker. And it was for the very first time that he looked into the role of radiotherapy following surgery. And as you can see here, that RT alone, RT plus BCNU and BCNU alone, basically it is shown that the median survival is doubled as compared to surgery alone. It was not until 2005 when Dr. Stuck a paper was published in the Journal of Medicine, in which he has compared RT alone versus RT plus temozolomide in concomitant setting along with the adjuvant setting for about 6 months. And he's shown that if you add temozolomide to radiotherapy, median survival goes from 12.1 to 14.6 months, and the two-year overall survival goes from 11 to 27%, which is almost double the 2 years overall survival. He also showed that if the tumor is MGMT hypermethylated, the median overall survival is 23.4 months, whether if they are not hypermethylated, then the median survival is only 2.6 months. This is a very latest paper from Czechoslovakia, in which they have treated about 160 patients. And they also compared radiotherapy versus radiotherapy plus temozolomide, and then they also gave adjuvant temozolomide too. And they found out that if you give them more than 3 cycles of temozolomide in adjuvant setting, they do much better than other arms. RTOG also looked into the role of bevacizumab along with the temozolomide, and basically they did not find any advantage adding bevacizumab to radiotherapy and temozolomide. Regarding radiotherapy fields, historically, I mean, we used to treat the whole brain, but gradually we realized that most of the recurrences are very close to the tumor bed. So now initially we use a little bit bigger field, we go to 46 gray, and we include T2 edema plus 2 to 3 centimeter margin, and then we tone down, and we give further total of 60 gray, and we include T1 post GAD enhancement with 2 to 3 centimeter margin. Contouring is extremely important, and you should use all the imaging pre and post-op to make sure that we only include the area which need to be included. Period. Radiotherapy dose. It was found initially that as you increase the dose from 0 gray to 60 gray, you see a dose response in high-grade gliomas. Is more the better? RTOG 9305 added upfront SRS to 60 gray BCNU arm and compared it with 60 gray plus BCNU only, and they basically find no difference in the median survival if you add SRS upfront. Post-chemo RT follow-up. Usually we do MRI at 1 month, and then we do every 2 months. If you do MRI at 1 month, half of the tumors are bigger, and of those half which are bigger, 2/3 are pseudo progression. If you look at this schema, that if you do MRI after 1 month, some of them will be enlarged and some will be stable. But you continue with temozolomide, and then you repeat the MRI after 3 months. If it is stable or reduced, you continue with temozolomide. However, if there is progression, then you stop temozolomide. In this group, they found out that those patients, almost 89% of them had tumor unmethylated MGMT, whereas in this group, only 1/3 of them were unmethylated. This is pseudoprogression. This is prior to RT and TMZ. This is 1 month later, and then 3 months later, and then 5 months. Almost you see a slight enhancement. Response assessment in neuro-oncology or renal criteria. They say that if you see progression less than 3 months after radiotherapy and chemotherapy, then if the new enhancement is beyond 80% acidose line, then you can call them tumor progression. Or if you got a biopsy, then you can call it true tumor progression. GBM in advanced age are lower KPS patients. And most of these, in practice, you can see that most of the patients are advanced age and they have lower KPS. There are multiple studies done in which they hypofractionated the treatment and compared it with the conventional fractionation. And they basically found that there was not much difference between conventional fractionation versus hypofractionation. And even some of the studies they did temozolomide only, and they found no difference in the elderly population. EOTC 26062 and NCIC, they did a randomized study looking into the role of TMZ along with hyperfractionated radiotherapy. And what they found that if you add TMZ, like stop regimen to hyperfractionated radiotherapy, it improves both the progression-free survival and overall survival in the TMZ arm, period. Especially in MGT methylated patients, there was double the benefit. It was presented in ASCO 2016. So in elderly GBM treatment schema, if the patient has got a good performance status, then you can do the standard treatment. However, if the performance status is not good, you can use TMZ alone if the tumor is MGMT methylated, or even you can do RT alone if MGMT is not methylated. Or even you can do, or the radiotherapy options are 40 gray in 15 fractions, or 34 gray in 10, or 25 gray in 5 fractions. For recurrent GBM, which is usually the case, majority of them, they do recur. There are different treatments, and one of the treatments they used was tumor treating fields. And they found out that these patients do better with this new technology. Basically, what it does that it creates a electrical field around the tumor, and hypothesis is this, that it is antimitotic. It interferes with the DNA repair. Autophagic improves immunological response to the tumor, anti-migratory, and also increase the vascular permeability. So if it is good for the goose, as I say, it's good for the gander. So next, what Dr. Stubb did, that he used this TTF in upfront newly diagnosed GBM along with temozolomide, and he found out that there's an improvement in the median survival. It's very expensive, almost cost $20,000 a month, and only 1/3 of the patients in the US are getting this treatment. High-grade gliomas, leukodendrogliomas. RTOG did a study looking at the role of PCV in anaplastic oligodendrogliomas, and so did EORTC. And they found out that there's improvement in the median progression-free survival. However, there was no improvement in the overall survival. And they also found out that if these tumors are 1p19q co-deleted, then they do much better when compared to if they are non-co-deleted. The new standard of care nowadays is sequential RT chemo if IP19q is co-deleted. We're also looking at the role of TMZ versus PCV. I mean, some people are using TMZ and some people are using PCV in these patients. And we don't know exactly which is better, but there's a Cordell study going on comparing these two drugs in anaplastic oligodendroglioma. In oligodendroglioma anaplastic, which are 1p19q intact, there's a subgroup which responds better. And if you look at it here, this is anaplastic astrocyte oligodendroglioma. If they are non-co-deleted and if they have IDH mutant, they do much better than the one which have IDH wild type. And you can see very well here, this is IDH mutant, non-co-deleted, and this is IDH wild type, non-co-deleted. Standard of care for anaplastic oligos that if they are co-deleted, they should get chemo and radiotherapy. And if they are non-co-deleted but IDH mutant, then they should also get chemo radiotherapy. However, if they're non-co-deleted and IDH wild type, they're as bad as GBM. In aplastic astrocytoma, nowadays we basically treat it as non-stop regimen. We give RT plus temozolomide. Low-grade gliomas. Again, you can see that molecular type trumps histological type. That in grade 2 and grade 3 diffuse glioma, if they are IDH1 mutant and IP19q co-deleted, their best prognosis. On the other hand, if they are wild type and they are non-co-deleted, then they have worst prognosis. You can see that here. Low-grade glioma with wild type IDH, they do as bad as GBM. This is GBM, this is low-grade glioma with wild type IDH. Whereas this is low-grade glioma with IDH mutation. A big difference. Again, the extent of resection is important in low-grade gliomas. The more you resect, the better it is. The greater the extent of resection, better is the overall survival. And low rate of malignant transformation into high-grade gliomas. Regarding role of radiotherapy in low-grade glioma, basically there are two things: the timing of it and the dose of it. What is the best timing? Immediate versus at recurrence. It was looked up by ERTC. And what is the best dose again? ERTC and RTUG. They did a study. Regarding the timing, they use a control arm, and other arm they give 54 gray post surgery, and then they give radiotherapy at the time of recurrence. They found out that there's no difference in the overall survival whether you do early radiotherapy or at time of recurrence. However, there's improvement in progression-free survival if you do early radiotherapy. Therefore, upfront radiotherapy improves progression-free survival, but not overall survival, and also improves the seizures at 1 year, and also does not increase the risk of transformation to the GBM at time of recurrence. Regarding the dose, they compared 45 gray to 59.4 gray, and they basically find no difference between 45 gray and 59.4 gray. And RTOG even went further. They compared 50.4 gray and 64.8 gray, and they find no difference. However, there were more side effects in this arm, high dose arm. So nowadays, the recommendation is 50 to 54 gray for low-grade gliomas. What about high-risk low-grade gliomas? And there are a couple of studies in which they look into the role of PCV. And they've shown that addition of PCV to radiotherapy in high-risk low-grade gliomas improve the progression-free survival. There's also a single-arm study in which they give 54 gray plus temozolomide, and they showed that the 3-year overall survival was better in the TMZ arm as compared to the historical arm, 54 in historical arm versus 55% TMZ arm. Even they have compared temozolomide chemotherapy versus radiotherapy alone in high-risk low-grade gliomas in ERTC study. And its early findings is that there's no difference, but again, we are waiting for the further follow-up on it. Well, thank you very much, and looking forward for the Q&A session. Thank you.
Thank you, Dr. Shahid. We'll be grateful if you could stay with us for the panel discussion at the end of the session. The next talk is going to be by Dr. Nelson Leong from the University of Saskatchewan. He's going to talk about stereotactic. He's going to talk about stereotactic radiosurgery and brain tumor management. Obviously, this is the holy grail of treating brain tumors without actually cutting the patient. So Dr. Nelson Leong from the University of Saskatchewan.
Hi there, I'm Nelson Leong, and I'm a radiation oncologist at the Allenbar Cancer Center in Regina, Saskatchewan, Canada. And today I'll be talking to you about stereotactic radiosurgery, or SRS, introduction and indications. I wanted to take this opportunity to thank the program organizers for inviting me to speak. I do have a few disclosures because I've received some speaking honoraria, but none of them should be interfering or convey a conflict of interest for today's discussion. I don't have any other relevant potential conflicts to disclose. Just a brief summary of what we'll be talking about today. So after today's presentation, you'll be able to outline the role for SRS in the treatment of brain metastases. You'll be able to describe the process of SRS in rough terms to a patient. You'll be able to describe some of the key differences between conventional radiation therapy and SRS, and also identify some of the common other indications for SRS, both benign and malignant. So I thought I'd start out with a little case. So I have Mr. D. He's a 57-year-old gentleman with locally advanced adenocarcinoma of the right lung. It was a T2N2 M0 at time of staging. The tumor was ALK negative and EGFR negative. So he was treated with concurrent systemic therapy, cisplatin etoposide, radiation therapy to a total dose of 60 gray and 30 fractions to the gross disease, and then adjuvant durvalumab for an additional year. Unfortunately, 2 years later, this gentleman presented with new onset right arm numbness and weakness. A restaging CT scan showed a recurrence in the liver, but it also showed a 2.5 centimeter lesion in the right occiput with moderate vasogenic edema in keeping with a single brain metastasis. We have some of the relevant imaging. We have an MRI here. So on the left, we have the T1 with contrast, which shows the tumor quite clearly, and then the correlating flare, which shows the edema around the tumor. So this patient saw both a medical oncologist and a radiation oncologist. The medical oncologists were planning systemic therapy pending his PD-L1 status, but in the interim, he was referred to the radiation oncology department to help manage the local symptoms and the local disease. So at the time of his assessment, he was an ECOG-1. He was alert, oriented. He had a little bit of decreased strength in his right grip, biceps, and shoulder, but significantly decreased strength in his right triceps. He had good strength everywhere else. He was seen by neurosurgery, but ultimately declined resection. So in determining what we do next with this gentleman, sometimes it helps to have an idea of prognosis. So I've pulled one of the slides from the graded prognostic assessment, and this was just updated in 2022. So it's a way of taking some patient factors, and now there's also tumor factors and tumor markers added to it. And we can use that to estimate a life expectancy based on their condition and how many of these features they have. So this particular gentleman being ECOG-1, he had a single extracranial metastasis. His GPA works out to be a score of 2.0, which would be an estimated 15 months of survival. The interquartile range for that is 5 to 38. So that's still a pretty big range, but 15 months is a reasonably long time for somebody with metastatic cancer. So we want to treat him carefully and need to consider the long-term consequences too. So some of the treatment options we have available to us are surgery, SRS, whole brain radiation therapy. That can either be done with the standard whole brain radiotherapy or hippocampal sparing. And then any combination of those three treatments, one, some, or all. Best supportive care, I should also mention, is a treatment option for patients, especially if they're unwell or aren't willing to go through any of these treatments. Talking a little bit about radiosurgery because it is the topic of today's conversation. Despite what the name says, I should point out that SRS doesn't actually involve surgery and no knives are involved. So it's generally actually a non-invasive procedure for the most part. Stereotaxy refers to mapping. So it's any planning atlas with a coordinate system which helps us localize a treatment onto a real patient to help with precision. So in this case, the planning system is use of the frame of reference for the radiation treatment unit and also using images that we can take from their skull and planning MRIs and taking that all together for a really precise high dose treatment. The actual radiosurgery component, part of it's a marketing term. So a lot of this does come from the United States. It's used to describe treatments in 5 or fewer fractions, often just one. The reason why the arbitrary number of 5 was picked was mostly for billing reasons, again, from the United States. Generally, more fractions are used for larger tumors. We'd go through some of the different tools that we can sometimes use to treat people with SRS. So this is a gamma knife. It was invented in 1968. And although the newer versions are just a little bit more slick, functionally, they're still about the same as they were when they were first invented, with a few extra features, obviously. The idea behind a gamma knife is that there are a number of cobalt sources around the outside, all focused on a single isocenter in the middle. These multiple beams are collimated, and when they all meet in the middle, it results in a really high conformal dose with a really sharp fall off around it, allowing us to give a high dose of radiation therapy to a very small area. One of the key things about this gamma knife, though, is that in this particular case, usually a rigid frame is required because we move the patient through the treatment area. The beams don't move because they're fixed to the cobalt sources. This is a linear accelerator, so it also happens to be the linear accelerator at my center, and that's one of our therapists modeling for us. So the linear accelerator produces X-rays, and we use a technique called VMAT or arc therapy, and usually a number of arcs to help provide radiation therapy to a brain metastasis. So in this particular treatment, the bed is able to correct for translation, roll, yaw, helping us line up the patient correctly. They're generally immobilized with a tight-fitting mask. So setup and precision is often to less than 1 millimeter. And we use things like cone beam CTs and extra X-ray imaging to help provide that precision. This is a cyber knife. Some centers use it. It also provides X-rays, and those are from the outside, but on articulating robotic heads. So that gives a lot of degrees of freedom, again, allowing us to provide high doses of conformal radiation treatment. So what are some of the advantages of SRS? Why would we choose to use it? Well, patients are definitely living longer. Part of this is because we're doing a better job of controlling intracranial, but also extracranial disease as we come up with new advancements in radiation therapy, surgery, but also things like immunotherapies and chemotherapies and targeted therapies. Patients are living much longer than they previously used to, and that's a good thing. But it also does mean that we have to be considerate about long-term side effects and consequences. In most cases, the neurologic symptoms from having intracranial progression or new disease is going to be worse than the side effects from treatment, but we do want to minimize these side effects. So for whole brain radiation, which previously was the standard of care, we know that it's toxic. So much of this is drawn from clinical trials for prophylactic cranial irradiation, particularly in lung cancers. And they found that there was a very significant increase in neurocognitive decline. So cognition, memory, but also a lot of patients will have quality of life changes like somnolence syndrome. So for that particular syndrome, some patients would sometimes sleep 18, 20 hours a day, and that can sometimes last for many weeks or months. We also use radiation therapy or surgery for treatment of intracranial disease because chemotherapies traditionally aren't very good at penetrating the blood-brain barrier. Now, this doesn't necessarily apply to some of the newer targeted therapies or immunotherapies. There's a lot more research that we need to do about that, but previously, the brain was kind of a sanctuary site against chemotherapy. SRS is a very effective treatment locally. It touts up to a 70% one-year control rate, sometimes even higher depending on the study series that you're looking at. Some of the reasons why this might be the case, well, we're able to dose escalate. So that radiation treatment is so conformal, and that means there's not a lot of spillage elsewhere. So that allows us to give more radiation without worrying as much about the side effects. That dose escalation, when we go to much higher doses of radiation, may also change the radiobiology of how that X-ray energy takes effect. So it may not be just simple DNA damage now. So there may be also an immune therapy effect, which could explain some of the synergistic effects it has with immunotherapy. And also this different mechanism may be one of the reasons why SRS is able to overcome what used to be considered traditionally radio-resistant tumors like renal cell carcinomas and sarcomas. So we've come to our break slide. So now that we're partway through our presentation, so I was going to play a game of this or that. So for those of you who are Jackbox fans, the object of this game is to determine which of these terms belongs to each category. So one of the categories is Harry Potter spells, and the other one is medical terms. So here are the terms. We have amorphous, flare, hippocampus, tarantellegra, and memantine. So I'll let you figure out which goes where. And here are the answers. So just wondering how you did there. For those who are curious, amorphous is, it was Professor Lockhart's werewolf cure, and tarantellegra is a curse that causes your unwary adversaries to dance. Moving on. So I'm just going to run you through what a SRS treatment using a linear accelerator would look like. So we start with the CT simulation, and this is actually the CT simulator in our department. So during the CT simulation, we set patients up with a thermoplastic shell. I'll show you what that looks like in the next slide. We take this information, we'll eventually use it to help calculate the radiation doses and also determine what we want to hit and what we don't want to hit. This is usually set up with lasers that can be reproduced later on. So the setup, again, can be to a millimeter or less. So we've got some pictures of the thermoplastic shell. As you can tell, it's pretty significant. Patients can still see through it, breathe through it, but it is quite firm. It starts as a wet cloth, cloth-like material, and as it cools, it hardens into the shape of a patient. That gets clipped into the bed, and it's quite rigid, so patients can't really move around or wiggle around. In the top right corner, there's a short video clip of an MRI unit and a couple people having fun there. I don't recommend doing what they're doing in your department to your MRI, but it was just a reminder just to talk about. We do a planning MRI as well, and that planning MRI helps us delineate the tumor, and it gets fused electronically to the CT that we obtain. So the next step is in the back cave. So for this component, we do some contouring, and so that's where the radiation oncologist and sometimes also a neurosurgeon will delineate the tumor or the target, but also delineate other targets that we don't want to hit. Then we involve a few additional staff people, so usually a radiation therapist who helps us plan, and a radiation physicist who helps us with the calculations and ensures that the plan that we come up with is actually deliverable by the machines. I have a couple plans here. So once we're done with the planning process, a plan is outputted, which is then given to the machines. I thought I'd just show you the difference between a whole brain and an SRS plan. So on the right, we have a traditional whole brain radiation plan. So these are usually done to a total dose of 20 to 30 gray. And so we have an equivalent radiation dose unit in gray, which is the unit of measurement for radiation. And so whole brain, usually somewhere between 30 to 40 gray. And as you can see, as the name suggests, the whole brain is included. On the left, we have an SRS plan. You can see that it's a lot more conformal, and a lot more of the brain is spared from that high dose radiation treatment. The dose itself is also higher. So on the low end, that equivalent radiation dose can be somewhere between 45 to 50 gray. But if we're doing a high dose single fraction treatment, sometimes that equivalent dose can be pushing the equivalent of 150 gray. So quite a bit hotter and probably different. There is some quality assurance that goes through. So we double check the plan, we double check the contours, usually second radiation oncologist involved because you can't take the radiation back. The physicist will also check the machine in the morning vigorously with films to make sure that the radiation is going to hit where we tell it to, and that everything is working as it should be. So everything is actually run through a dry run and then vigorously tested on the day of treatment. The actual treatment itself, so obviously usually we have a patient in here, but they get clipped into that thermoplastic shell. We use the lasers indexed to that frame and the bed to make sure that the patients are lined up in the correct location. Then the radiation unit's actually able to take a combination of X-rays, like plain film X-rays, and also CT scans to make sure that the patient's in the correct location. And we can match that using 3 dimensions because that CT scan is a 3-dimensional scan. The radiation treatment itself is then delivered. So we usually have like 4 or 5 arcs in different locations, and that whole process usually takes somewhere between 30 to 40 minutes start to finish. So after the radiation therapy is done, there are some potential side effects. So in the short term, patients can have edema like nausea, dizziness, seizures, headaches. Most of that's from acute edema. We usually treat that with dexamethasone or an increased amount. Depending on your medical provider, some will elect to put them on it prophylactically. Late side effects, so about a 10% risk of radiation necrosis depending on the dose. Half of these can be asymptomatic though. The symptoms usually have focal neurologic signs, almost like a stroke. But many times the side effects of the tumor progressing could be worse than the actual side effects from the radiation therapy. Combining the treatment with immunotherapy likely also increases the risk of necrosis. So I thought I'd run through some of those other uses for SRS. So we can, in terms of malignancies, so meningiomas are really common to treat because they're nicely circumscribed and we want to give them a high dose. Gliomas are also an area of investigation, especially for recurrent tumors that have already seen some radiation therapy. It's not standard of care, but it is something that's under investigation. There's a lot of different indications for benign tumors or problems as well. So AVMs, schwannomas, adenomas. Some of the functional diseases like trigeminal neuralgia, epilepsy, and tremor can also be treated with the stereotactic radiosurgery. And oftentimes we have the neurosurgeons help us out with that. It's a multidisciplinary treatment. So future directions. In the future, we want to probably look at combining things like targeted therapies or immunotherapies with SRS, again, exploiting the fact that there seems to be a different mechanism of action and possibly allowing us to overcome some of the treatment-resistant tumors. Recurrent gliomas, as I mentioned in the previous slide, those are something that we're also looking into investigating across the world because that conformal treatment may help us dose escalate, being a little bit more effective against this very devastating disease and potentially cutting down on toxicity, but still a lot of work to be done there. Well, with that comes, we're coming to the end of our presentation. I have a slide just here with our stereotactic radiosurgery team in Regina. And so from us to you, I want to thank you very much for participating in today's conversation. And I'll just close out with a goodbye and 2 slides of my dogs. So thank you very much. And I look forward to chatting with you in the panel to come.
Thank you, Dr. Nelson, for your excellent talk. We'll take any questions at the end of the session. I'll introduce our next speaker. It is Dr. Osama Khan. He's a consultant neurosurgeon at the Northwestern University, Feinberg School of Medicine, Chicago. Dr. Osama has special interest in skull-based neurosurgery. Kindly have the recorded. Thank you.
Hi, my name is Dr. Osama Khan, and I'm a neurosurgeon at Northwestern Medicine. So the type of cases that I see are usually related to brain tumors, and those range from anywhere in the skull, in the brain, or in the spinal cord. The typical treatment for brain tumors requires a multidisciplinary approach where we like to take into consideration the patient's imaging, their clinical exam, their history, and of course, their hobbies and their way of life. So what I want patients with brain tumors to know is that there are options available for treatments for their brain tumors, whether that be a minimally invasive approach for resection of their brain tumor, or whether that be an awake surgery where we can safely resect or remove abnormal tissue from the brain, such as gliomas or metastases, and newer technologies that are available, such as laser ablation, or using the intraoperative MRI here at Northwestern Medicine to ensure that we get a great resection and not causing any harm. Some of my clinical research is interested in finding better ways of detecting brain tumors, better ways of managing, and better ways of following these lesions in the brain, looking at the brain tumor samples and finding out how these can be better detected either in the blood or also in the brain for better responses to treatment. Hi, my name is Dr.
Technical issue, so I think Dr. Irfan Yusuf has gone to check whether Dr. Osama is online. If so, maybe he's going to talk online.
Yep, I'm here. Happy to present my slides in live. That's fine with me. Unless you want to try one more time using the video that was provided. Do you guys want me to try sharing my video?
Assalamu alaikum, Dr. Sama. Irfan here from Lahore. Sorry, we had some problem loading up the recorded presentation. Is it possible for you to share your screen?
Sure, happy to. I'll share right now.
Thank you very much.
Let me know if there's any difficulty with it.
Yeah, it's working. It's working. Thank you. We can't hear you at the moment.
Let me know if this works now. Let me know if you can hear the audio, okay?
Sure.
Good morning. I'd like to thank the organizing committee to allow me an opportunity to participate in such a interesting seminar. I'm going to talk today about endoscopic approaches to anterior skull-based tumors, techniques and outcomes. I have no disclosures. It's important for me to mention my mentors. Here listed are Dr. Morkos, my mentor in fellowship, Roy Parkinson, retired neurosurgeon in Winnipeg, Canada, that first described the cavernous sinus and approaches to the cavernous sinus and anatomical landmarks. Dr. Fred Gentili, skull-based neurosurgeon in Toronto, and Dr. Ted Schwartz at Cornell, where I did some of my research. So when chatting about endoscopic approaches to the skull base, specifically to the sellar region, Dr. Morkos, who was kind enough to allow me to borrow this slide, talks about the Scott's parabola, which is the rise and fall of surgical techniques, where you go from a promising idea of possible value but only research, to encouraging reports, to widespread enthusiasm, strong media pressure for universal acceptance, a general introduction, and then standard treatment. And then it starts creeping into doubts, damaging reports, to widely publicized medical legal cases. And then it starts to fall into disuse, where very old surgeons amaze their juniors with rollicking stories of the old days. So I want to describe how Marcos would tell me how this is similar to what's happened with endoscopic endonasal approaches to the skull base. I'll go back to that slide, but for today, the objectives will be to review common pathology of the anterior skull base and appreciate the indications and limitations of the endoscopic endonasal approach. Surgical approaches to the skull base are widely accepted. Open surgical approaches, basically transcranial, where a bilateral approach can be used, such as a bifrontal or subfrontal approach, subcranial, bilateral, transbasal, interhemispheric for large anterior skull base lesions, to more unilateral approaches, a pterional or OZ, a modified OZ, transsylvian, and then you can cosmetically go down to a supraorbital mini craniotomy eyelid approach. But once again, today's topic will be more of the transfemoral approach and even expanded endonasal, where once again, an approach through the nasal cavity with the help of our rhinology fellows and colleagues, we can approach the anterior skull base to resect tumors. So once again, here's another view, but today the focus will be on our approaches to this region of the sella, where we have the clivus, the sella, where the pituitary gland sits, and we're talking about the tuberculum and planum region for anterior skull base tumors. A visualization now through the nose at the base of the skull. Ultimately, our rhinology colleagues will give us this approach, where we will then be looking closely at the clivus region, the sella, and these landmarks of optic carotid recess give us landmarks of where the chiasms will be, the chiasm and optic nerves will be, and where carotid arteries are, which will then allow us to get this exposure for bony drilling to ultimately have dural opening. And this is something that we'll get back to, but here's your pituitary gland, which behind the chiasm and optic nerves is the stalk. So once again, from craniopharyngiomas, pituitary adenomas, chordomas, or meningiomas, all this could be approached through an endoscopic approach. So I'm going to show you a few cases that illustrate the approach, so you have an understanding of what this entails. Here is a sellar mass seen in axial view post contrast, showing displacement of the chiasm. Enhancement here in the sellar region. In the sagittal view, showing some central necrosis. This was a female with a non-functioning adenoma presenting with amenorrhea. Here, this view of a case that I did with Dr. Schneider, my rhinology colleague, and just illustrating the approach that with their help, we ultimately get the view that I showed you before of the sellar region. Here's the opening of the dura in a cruciate fashion, reflecting the dura open. And what I like to first do is just do an extracapsular manipulation of the mass so that we don't have to get inside of it and internally debulk it if it's soft enough and fibrous enough to do so. So by using microsurgical techniques, basically going around intradural but extracapsular, so that you will slowly see this mass coming outside of the sella on its own, just due to manipulation and staying outside of it. Obviously, there's some aspects of it that end up herniating through. The capsule gets a little thin, but you can see it's all coming out in one piece or en bloc. And eventually you'll start to see the arachnoid and the pituitary gland as we go deeper around this mass. And there you can see the arachnoid now bulging in. the mass still all together. Here's just some pieces that were left towards the back part of the cella or against the cavernous sinus wall, but we'll see here, just peeling off just a little bit of the arachnoid left. And the capsule coming off. Oh, you can see a thin shadow of arachnoid right here. Now it's all removed en bloc. There's the adenoma, and then we can ensure that there's no residual left with Corette's against the cavernous sinus walls. And because it's beyond the scope of this discussion, basically we do a multi-layer closure, Surgicel, inlay, overlay, and nasoseptal flap, and sometimes some fat after fibrin glue and Surgicel. We have the luxury of an intraop MRI at our facility, so it helps for me to ensure that we obtain a gross total resection, and here you can see a gross total resection of the adenoma. So craniopharyngiomas also, as you remember, arises from the pituitary stalk. And here is a older female with this cystic mass in the suprasellar region. If you could appreciate, it's actually above the pituitary gland, especially see that in the sagittal view. Here's the pituitary gland, here's the stalk from which it arises, and then it has this cystic component that enters into the third ventricle. So the advantage of a endoscopic endonasal approach is that we can visualize the pituitary gland and actually see the stalk from which it arises from. You can see that early rather than an open approach where you end up having to see that later on. Here's the dural opening. And just like you see on the diagram on the right, after arachnoid opening, you can now see, just like this pituitary gland below, the stalk right here, which you can see the fat infundibular or stalk, of which this is the origin of the craniopharyngioma. And you can see chiasm here, optic nerves, and optic tracts behind it. This microsurgical techniques, we can isolate and find exactly where this pituitary stalk turns from normal to abnormal. Here's the vascular supply coagulated and dissected free. Coagulation and then sharp dissection and disconnection. And then usually you're able to remove this craniopharyngioma en bloc, but this was removed piecemeal fashion due to its adherence to the surrounding structures. And at the end, you can basically see the posterior circulation and arachnoid all open up here. And after multi-layer closure, you can see above the MRI showing, once again, the gross total resection. You see the stalk, the pituitary gland still here, chiasm, with disconnection, obviously, with no stalk, given that that's the origin of the craniopharyngioma. Sometimes you are able to do stalk preservation. You can see in that image that it was entirely surrounded. You can also resect clival chordomas. Here's more of a clival rather than more suprachiasmatic extension, but you can see enhancing lesion in the clival region. You can see it's below the stalk. Here's a chiasm stalk, and the pituitary gland is probably pushed or elevated. Once again, endoscopic approach after our rhinology colleagues give us the visualization. You can then appreciate and use microsurgical techniques of this very easily suckable lesion that can be removed in piecemeal-like fashion. Coming out in lots of larger pieces. Once again, this can benefit from an intraoperative MRI where we can ensure gross total resection. You can see the axial views here, the coronal view with the pituitary placed superior to the right. And here's sagittal view where you can see the pituitary gland now a complete resection of this chordoma, which ultimately would end up getting proton therapy after at our facility. Here's a supracellular extension of a clival chordoma. Once again, you can see the heterogeneous appearance, and it is all extradural and pushing the pituitary gland. You can see it right here as well. So an endoscopic endonasal gives a great approach, great visualization. The next part of the talk I was going to look into is describing approaches to meningiomas. This is an area of controversy throughout the literature and much discussed at skull-based meetings of whether the anterior skull base meningioma should be approached endoscopic endonasal or open. Here's an example of one of our cases done endoscopic endonasal, where you can see a near gross total resection with some residual here near the tuberculum. One of the disadvantages, once again, of endoscopic endonasal has been widely reported of more likely a residual than an open approach. But you can appreciate here an endoscopic approach can get you to the lesion without any brain retraction and being the advantage. But there are other advantages, and I'll go through it here. Refractory groove meningiomas arise from the cribriform plate or the frontosphenoid suture. You can see here this more anterior meningioma, and whereas the tuberculum arises from the tuberculum sella, chiasmatic sulcus, and diaphragma sella. You can see here this most posterior placed ones. And well-published reports on this by one of my mentors, Dr. Schwartz, and also Rick Komatar Miami, was this comprehensive literature review, which showed that the extent of resection in open refractory groove is so much higher than an endoscopic approach, with a high degree, 30% rate of CSF leak when it's performed endoscopic versus open. That's very high for us. And once again, this is an older series from 95 to 2010. And during this era was the development of a way to help reduce CSF leak called the nasal septal flap for the skull-base reconstruction, which I think really has changed our ability to prevent stuff like CSF leaks. Tuberculum meningiomas, once again, you see that the extent of resection might be comparable. Once again, CSF leaks is just too high at 24% versus 4%. So that is one of the risks when approaching these lesions endonasally. So because of this interest during my time in training, I reviewed not only our data in Toronto with the olfactory groove and tuberculum, but also the data with Ted Schwartz and his group in Cornell when I did a research fellowship there during my training to see what was their experience and what kind of benefits did they see in their type of closure and how we could benefit from that. These are the pluses and minuses when you look at the difference between open and endoscopic approaches. We as surgeons are more comfortable with the open approach than the endoscopic. Obviously, there's a cosmesis when you do an endoscopic approach. In meningioma surgery, you want to be able to coagulate the dura and remove bone before. And so that's the advantage of the endoscopic approach. Obviously, you have less brain retraction, the endoscopic, the fact that you're going from underneath rather than open, and less retraction of nerves and vessels. And you have access to the space medial to the carotids from below, whereas from above, you have access lateral. We'll talk about why that's a difference in advantages of open versus endoscopic. And you have early identification of critical structures in an open approach, because this is explaining the carotid and optics above. You get to see that, whereas from below, you only see that at the end. Ability to remove unexpected tumor tails, you can do that more open. Example is the case that I showed you on my end, where residuals left. But then ability to remove cellular extensions that go down is better from an endoscopic approach. Now, our ability to handle structures is a lot easier with the open. Ergonomics of surgery, we're just used to using two hands with more manipulation and more efficient movement of instruments in and out of the field. Reverse complications with an open approach. CSF leak, arguably, this is from a paper with Ted Schwartz. They said that it was lower in their series, but I'll mention that in a second. Minimal access with endoscopic, but maximal invasiveness arguably is the same. So when we're talking about complexity of endoscopic endonasal procedures, we start with pituitary surgery, maybe with CSF leaks is next, then we go to extradural tumors, and then to intradural tumors, and the question is this level 5 concept of cerebral vascular surgery, which I'll mention in a second. Let's go back to meningiomas. So here's the anterior skull base, so refractory groove and tuberculum sellae with pre and post-op imaging of extent of resections, gross total sections in both. This is a series in Toronto where once again, our rate of CSF leak was pretty high at this time of olfactory groove and tuberculum sellae. And here, this is just the paper that we had published in 2015 with the Toronto group comparing to other centers, where once again, just reestablishing the high rate of CSF leaks throughout this various series. But with Dr. Schwartz and Cornell, we talked about how can we predict the meningioma success with relation to our cortical cuff, that is that brain surrounding, tumor surrounding the vessels, and how that can limit your extent of resection, and showing once again his series of cases of refractory groove and tuberculum resected gross totally. And the contraindications is usually related to the extension of tumor lateral to the optic nerves and the optic canal. Maximum extension 3 centimeters above the intracranial fossa. We just feel that that's just hard enough for us to reach with our instruments and have microsurgical techniques. The presence of extreme aspirator frontal lobes with a lot of edema or hydrocephalus, which just gives us concern of not only brain manipulation and edema, but also the hydrocephalus can lead to CSF leak. The significant hyperostosis, often associated with meningiomas, can be difficult for us to drill and prolong the surgery that is already long enough. Previous endoscopic surgery or previous craniotomy is a relative contraindication, depending how comfortable you are in operating on other people's surgeries versus your own. And this concerning features on MRI for malignant disease. These are another paper looking at how can we benefit from an anterior skull-based approach by going through the ethmoids, the frontal sinuses, the back wall to help exposure. So it's a cadaveric study with clinical case. So this is me back in 2013. How can we take advantage of just using a few more millimeters and entering into the frontal sinus called a graft 3 or modified Lothrop? See if that it gives us a better exposure by using cadaveric measurements and clinical examples. We showed that it could help in your approach to skull-based tumors. So going back to the Scott's parabola, as we discussed at the start of the presentation, standard treatment of cellular lesions has now become endoscopic endonasal approaches. And with anterior skull-based meningiomas, arguably, it's starting to creep in doubts for myself. I do have a preference to rather go open than endoscopic because of, once again, all the data that's out there, the data of those having success of 0% CSF leaks, or even in the single digits. Obviously, there are very high volume places with expertise and ongoing research, whereas I think the majority of us feel that that could be too much of a morbidity for patients. And whereas aneurysms, I think there's published reports of this, but I think that there is some skepticism in the field, and all of us feel that there's some limits to what we can do from a safety point of view. So I'd like to thank everyone for allowing me to present this topic of endoscopic endonasal. Thanks to my ENT colleagues, Dr. Fishman, Brown, and Schneider for all these cases and helping me gain these approaches, and my nurse practitioner, Kelly Schaefer. Thank you. I'll stop sharing.
We all have an interest in pediatric posterior fossa tumors, which are a large percentage of the work that we do here. So Dr. John Caird from Beaumont Hospital in Dublin, which is the premier neurosurgical institute in the Republic of Ireland, is going to talk about the surgical challenges, techniques, and outcome in pediatric posterior fossa tumors.
Good afternoon, ladies and gentlemen. My name is John Caird. I'm a pediatric neurosurgeon practicing in Dublin. And I'd like to thank you, thank the staff and the faculty of the Shaukat Khanum Memorial Cancer Center for kindly inviting me to participate in your 21st Cancer Symposium, a great achievement. And I'd like to offer my thanks and congratulations to the chair of the symposium, Dr. Mohammed Parvez, and his co-chair, Dr. Kashif Sajjad, and also to my old friend, Dr. Irfan Yusuf, who was a trainee with me, a trainee in neurosurgery here, both in Dublin and in Belfast for many years, and we enjoyed each other's company, and he's greatly missed here in Dublin, and I know he's doing great work in his home country of Pakistan. Irfan kindly asked me to get involved in today's symposium. I'm going to speak a little bit about the technical aspects of posterior fossa surgery in children. And myself and my neurosurgical colleagues here in Temple Street Children's Hospital in Dublin, there are 4 of us. We operated about 55 cases of new brain tumors and spine tumors per year. So we do one every, individually do one every couple of weeks. So we're not hugely busy. I know you guys have a much larger practices in terms of the numbers of patients coming through. But I'll maybe go through a selection of cases that we've had over the last 18 months or 2 years or so, just to give you a flavor of what our cases are like, and maybe talk you through some of them. I'll start with this patient here. This is a 2-year-old girl who presented with a couple of weeks onset of cranial nerve palsies, and she had a new squint, and she had difficulty swallowing, and she had this large pontine tumor on her MRI scan, which you can see here. And so what we did for her was we did a stereotactic biopsy, and we placed a shunt under the same sitting, probably exactly what you would do as well. We used a trajectory through the right cerebellar peduncle, which we did first. We did the biopsy first, and then we put the shunt in second. We used our navigation system is a Stealth S8 system, and we have usually for brain, when I'm doing a brainstem biopsy, I get our navigation engineer from the company to come and join us for the case. It just takes a lot of the navigation technology stuff off your plate, you enough to be thinking about without having to be fighting with the machine. So I always get the engineer, the navigation software engineer, to come and help us with those. And it's just, there's so many buttons and different functions that you're never going to know them all. And if something isn't working properly, they're much quicker, more adept at sorting it out. So my first piece of advice when you're doing something complex like a brainstem biopsy, get help. Always get the help of a navigation engineer or another consultant. I always like to have a second consultant, at least in the building, when I'm doing one of these cases. So this turned out to be a diffuse midline glioma. And I know our neuropathology specialists have their world has become immensely more complex in recent years with the advent of a whole raft of new molecular diagnoses, and we have to wait now for an integrated diagnosis. 7 or 8 years ago, a simple histological diagnosis was sufficient to inform the parents, but that is no longer the case now, and we have to usually wait, even though the diagnosis is blindingly obvious on the scan, the very first scan, but you have to be certain, I guess, now, and you need it written down before you can talk to parents about a lethal diagnosis, which is, I suppose, reasonable. Excuse me. So obviously you have to reposition. We tried, if they're 2 years or more, we'd probably use pins. If they're less than 2 years, we'd probably use an EM navigation, which is pinless. So you just use them on put the patient in a head ring without having to put the head in a Mayfield head holder. So I think it depends. The age is rather age dependent. On very small kids, obviously, you can't be putting skull pins on. If we go on to our next case, this patient is a 3-year-old boy who presented to us with symptoms and signs of obstructive hydrocephalus, and he has a large midline posterior fossa tumor, and he had surgery for this. He had it gross totally resected, and one of the key technical points we have for these patients is to ensure that they're properly positioned, and to we put them obviously prone, and then with the head flexed. Now, one of the challenging situations we had with flexing the head is that the ET tube can get kinked, and you can be barreling along through your craniotomy when the anesthetist pipes up that the airway pressures have increased and that you have to stop what you're doing, close the wound, take the patient out of the pins, and either re-intubate or take the pressure off the ET tube. And that can be a real pain in the neck. So it's key when you're positioning these patients prone and flexed in pins that you allow, I usually take a bathroom break around this time and allow the airway to settle. And by the time I've come back, it's either good or it isn't. If it's not good, then just reposition. You need a reasonable degree of flexion to be able to do it. But it's I think it can be challenging if you can't flex them properly. Anyway, for these midline posterior fossa tumors, I don't tend to use navigation, but we do use intraoperative ultrasound, and certainly we've recently, in the last year or so, got a very good quality ultrasound machine. Up to that point, I was using the one that our anesthetic department used for putting in radial arterial lines, which isn't great for brain surgery. So we have a specific one now that we use for tumors, which has it's appropriately calibrated to brain tissue, and there are still too many buttons on the front of it, but the ones you need are the depth and the there's another button, the on button, obviously. That really the only two ones you really need, and use the biggest probe that you can fit in the hole. But intraoperative ultrasound is nearly as good as intraoperative MRI, and I find it enormously helpful, particularly for midline posterior fossa tumors, where the anatomy is fairly well defined. And it was very helpful in this case, certainly. Now, here's another posterior fossa tumor. This is of the tectal stroke pineal region. And initially, I had done a biopsy of this and turned out to be a pilocytic astrocytoma. But it started getting, and I was hoping not to have to intervene surgically with it, but he'd had an ETV when he presented. He had presented with acute obstructive hydrocephalus. So he had his ETV and it was well. And then his vision started becoming more of an issue, and his teachers were concerned. And so we went after it through a posterior fossa approach, a superior cerebellar infratentorial approach. And again, the key for these is to get the head flexed enough that you can see down when the microscope easily when I'm operating on patients in that position, like the Concord position, that that I'm standing where the patient is prone. I'm standing sort of at the left-hand side of their body because I'm right-handed, and looking up the long axis of the surgical corridor. Rather than standing at the top of the table, I find it difficult to do that from that angle. So that's the main tip I would use for that. Also, intraoperative ultrasound is extremely helpful here. For this case, I would definitely use intraoperative monitoring. We use SSEP and MEP monitoring for this, and likewise the last midline posterior fossa tumor as well. We tend to use intraoperative monitoring for those cases. It's really more of reassurance than anything else. We've only been doing that for about 5 years. We had obviously been doing it for the intramedullary spinal cord tumors, but now the posterior fossa tumors, certainly if they abut the brainstem or the floor of the fourth ventricle, then we use monitoring frequently. Now this is a different kettle of fish. This girl presented with a torticollis, a head tilt, and being unwell over just a couple of weeks. Now, it was quite a challenge. My initial plan for this girl was to do a bony decompression of the upper component and to take a biopsy. Now, unfortunately, even before we got started, she went into, by positioning her and flexing her a little bit, she became so bradycardic, we thought we'd have to give CPR. She had quite a significant pause of about 30 seconds without of asystole. So I just did a bony decompression, and in fact, she went to Paris to have her biopsy done then. And she was found, interestingly, on the molecular studies found that she had a particular mutation and she has had proton radiotherapy, and she's on an inhibitor for her particular mutation. I can't remember the name of it now, but and she's still alive now, over 2 years later. But I think her disease is gradually progressing. It is a high-grade tumor, and I think over time will gradually progress, unfortunately. But certainly there were technical difficulties with her case, in that we very nearly had to give her CPR even before I started the surgery, which was not the best way to start. So this girl has an ependymoma, a posterior fossa ependymoma. She is 4, and again presented with acute obstructive hydrocephalus. I think we put an EVD in at the start. Now, one of the things that we've been doing more recently, I know many centers do third ventriculostomy as the sort of upfront CSF diversion procedure for patients with obstructive hydrocephalus. I haven't had such great outcomes for ETV in my hands. Maybe I just don't do them very well, but and certainly some of my colleagues who've done them, some of them have needed shunts following that. I prefer, maybe it's because I'm a little old-fashioned, the external ventricular drain, and then the surgery, and then challenge the drain and see how they get on. And if they fail the challenge, I put in a shunt, because life is complicated enough for these patients. They have enough uncertainties in their lives around the time of surgery, and adding is their ETV working or not to the equation, I don't think it's terribly helpful. So I think I prefer using a shunt generally for these patients. It's just, it works, even though we know ideally patients don't like to have a shunt, but you got to get over it, I guess. The ependymoma patients, they're a particular group who we find very challenging. They're it's the sneakiest of disease, ependymoma. We've had patients who've been clear for years, and then on their last surveillance scan, maybe 7 or 8 years later, bingo, there it is, the recurrence, the late recurrence, when they're now a teenager, and it's a really horrible disease. And because there is no effective chemotherapy. Now, we have had a few patients, we've had a few patients who have recurrent disease that we haven't resected for various reasons, and they've been put on oral etoposide, and that's held them well for a number of years. Even though you wouldn't have anticipated such a good outcome for them, but they've done quite well. It's clearly not a curative thing. It kind of holds things steady for maybe a year or two, or maybe a little longer. But ependymoma is certainly one of the more significant challenges. This one was a midline fourth ventricular ependymoma, and we certainly use intraoperative monitoring for these because they're very prone to a neurological deficit if it arises from the floor of the fourth. I'll just run you through. This is another patient with ependymoma, and this little fellow, this is a coronal image, you'll note, had recurrence in his brainstem and cerebellum, and this was like 5-6 years out after his initial surgery. He'd had his initial debulking of the CP angle tumor. It was really going. It was coming out. It was rising the floor of the fourth, going out through the foramen of Luschka into the CP angle, and one of the challenges, certainly one of the technical challenges we have, if you have to open the dura at the foramen magnum, if it goes down through foramen magnum down into the cervical spinal canal, if you have to open the dura for these patients to winkle out the tumor that has gone into the spinal canal, make sure you do it in the midline. And in one case, I made the error of approaching the foramen magnum laterally in a child and opening the dura laterally, and you will find a large venous sinus. I can't remember which one, probably the sigmoid sinus, traversing that, and if you find it with the scissors, the bleeding is incredibly brisk, and you'd be very lucky to be able to rescue the situation. So one piece of advice: if you're opening the dura at the foramen magnum, do it in the midline posteriorly, and that means maybe zigzagging your incision across, even if it's a CP angle approach, but beware of the opening the dura at the foramen magnum, because you can get extremely brisk bleeding there, and it's very difficult to control. So that's certainly one thing I learned operating in the CP angle in small children. But recurrent ependymoma, this fellow did recur 6 years post-op after his initial resection, and this is in fact his recurrence. And we let it slide for a little while. He was on oral etoposide, and then we thought, well, look, he's still going to school, he's still quite well, and there was much discussion about whether we should go back again or not. And after much toing and froing, we elected to go back and resect. Now, he'd only actually gone home last week, having been in hospital for about 8 weeks post resection, maybe 9. He has no swallow or gag post-op, so he's fed by NG tube. He was retaining CO2, so he was oxygenating quite well and ventilating quite well, but he wasn't breathing off his CO2, so he was becoming very agitated and encephalopathic with hypercapnia, and that's quite a tricky thing to treat. So he's on now on a nippy non-invasive BiPAP machine at night, and mostly on room air during the day, but he might need a little ventilation during the day as well. But so whether he'll be able to return to school or not, we don't know. Probably not for the foreseeable. But I think, and he's getting a peg tube fitted in the next few weeks. But I don't think he'd be able to swallow again, unfortunately. But he's alive, and he's been well debulked. That large lump you could see there is now a big black hole, and hopefully he'll get a few years out of it. But ependymoma is, as I mentioned earlier, the sneakiest of sneaky conditions, and it will come back and bite you. Now we move on to the happier tales. These are the pilocytics. We love to see these because A, the surgery isn't usually that difficult, and B, they have an excellent long-term prospect, which is, it cannot be said for ependymoma or often for medulloblastomma. This girl was about 6, I think, and she had this midline enhancing mass, and you can see the mural nodule and the cystic component. I did use intraoperative monitoring for this. I didn't use navigation. I did use intraoperative ultrasound, and it went well, and it's all out. And it's always gratifying to have the almost certainty of a good long-term survivor for these patients. I should have mentioned earlier with the medulloblastoma group, obviously it's a malignant brain tumor, WHO grade 4 tumor. However, with the molecular subtyping of which I'm sure you're very familiar with, has allowed some of these patients to avoid receiving radiotherapy, and that's been a massive benefit to that subgroup of patients with medulloblastoma who do not require cranial radiation, because it's as you know, I'm sure as well as we do, that irradiating the immature brain causes neurological havoc in years to come, with growth retardation, mental retardation, and general bad things happening, hypopituitism, all of that. So if you know, that's been one of the massive developments for in pediatric neuro-oncology has been the subtyping of medulloblastoma to allow a small subgroup of patients to avoid radiotherapy. I'll move on then to our next case. Again, another nice cerebellar hemisphere polycystic astrocytoma. These are probably the nicest of all. The surgery is dead easy. You just have to position them with make sure that the area where the lump is positioned uppermost. So you put them prone and turn the head and flex it so that the cerebellar hemisphere is uppermost, and then do a wide craniotomy. And I use the ultrasound then before I open the dura, and then open the dura widely, and then you can usually get around the lump relatively easily. They're usually quite nicely demarcated from the surrounding brain tissue. Again, this is a pilocytic astrocytoma, and a gratifying operation to do, and much less technically challenging than the ependymomas. They really are. For ependymoma cases, I absolutely, if I'm certain, if it's a CP angle, it looks like ependymoma, I make sure that there's another consultant surgeon around. If they were on holidays, I would wait until they're back. Because having a second pair of eyes look in on a case is very important, particularly at the end of a long case. When you're tired, you're not quite sure what's brain, what's tumor, get a second pair of fresh eyes in to have a look. And that has saved my bacon on a number of occasions. And conversely, I've, when I haven't done it and there's been a significant residual, then you just have to bring them back another day. And it's a whole another trauma for the patient, their family, and yourself. So you can reduce your burden by getting a second pair of eyes in to help out. Now the next one. So this is an interesting fellow. This chap presented to us. He was about 7 or 8 at the time. He had presented. He was to his local optometrist with difficulties in his vision, and he had papilledema. And then he came to the hospital. He had a scan which showed obstructive hydrocephalus, and you can see that the tectum is very thickened, and there's obstruction of the aqueductus sylvius here. So he had a third ventriculostomy, and that was fine. And we didn't do anything with his tectal lesion. These are benign, indolent grade 1 tumors that don't tend to bother people, and we leave them well alone. And that was fine. He had his ETV, and he was perfectly well for 4 or 5 years. And then his vision deteriorated again. He got some headaches. We rescanned him. His hydrocephalus had reaccumulated. His ETV had closed over. So he had a third ventriculostomy, and that went fine, and he was well, and his vision got better, and all went back to normal. And that lasted about 2 years, maybe. And then the headaches came back again. And so we thought, well, look, if the ETV isn't going to take, we'll just do a shunt. So we put a shunt in, and he was well. but we had difficulty with over drainage symptoms. He was getting a lot of postural headaches. So we then switched his valve, I think in the last year to 18 months, to a Certas programmable valve, which is an MRI compatible valve, and ticks all the boxes. And that it's programmable, it's MRI proof, so it's ideal for somebody that's going to have ongoing MRI surveillance throughout their childhood, and that was great. But he was getting some over drainage symptoms, and so we dialed his shunt up a bit, and then he came back in with headaches, and I did a scan, and he developed subdurals. So I told my registrar just to dial the shunt up a couple of notches, and what I hadn't realized was that in the Certas valve, if you go from 6 to 7, you're just moving up a notch. But if you go from 6 to 8, you're turning the shunt off. I hadn't realized that. And we turned it, the shunt was turned off, and he came back in a coma. And this had been a very high achieving youngster. He gradually recovered from his coma after placing external ventricular drain as an emergency. But he's never regained his intellectual capacity. He was an extremely bright young fellow with a tremendous academic future ahead of him, but that's all gone, unfortunately, due to acute obstructive hydrocephalus from turning a shunt off, which wasn't a fantastic idea. So if you're using a Certas valve, do not put it to 8 unless you mean to turn it off. I've written to the company about it because it's something that I was unaware of. Excuse me. Now, but nonetheless, with regard to the tumor, we don't have to operate on the tumor itself. We just continue to watch it with scans. This is another fellow with a tectal glioma, and his tectal tumor, he got an ETV as they tend to do, and that's worked fine. And this is, you can see his initial presenting CT scan here, the area of low density, the region of the pineal here. It's the tectum of the midbrain, actually, which is bulky. But it also extends out into the left posterior thalamus on the left side. And his tumor did grow, and we did end up biopsying this. And this is a pielomyxide astrocytoma. So these are a grade 2 tumor, and they tend to grow. And he did end up coming in and having debulking of his tumor. And then he, because it started to grow back again, he then went on to have proton radiotherapy. So not all tumors of the tectum are entirely benign, and certainly if they go out into the thalamus, if they're not purely surrounding the aqueduct, if they're off center, I would keep a very close eye on them. This is actually a big way, but his MRI scan, you can see it's not just a tumor of the tectum and pineal region. It goes off out into the thalamus on the left-hand side. This is a fascinating girl. She was only, I think she was less than 2 when she came to us with, again, a gross hydrocephalus. And she has this on her presenting a CT scan, it's a non-contrast CT. You can see this very large mass occupying most of the posterior fossa. In fact, it was hard to know where to start. But you can see that in contrast to the scan a few minutes back, this is hyperdense on non-contrast CT. I often find the initial CT scan is a very good predictor of whether the tumor is going to be a benign or malignant tumor. It's not foolproof, but it's if it's hyperdense on non-contrast CT, it's likely to be something ugly. And this turned out to be a medulloblastoma, and she had a very extensive tumor. And I think I'm not sure if we got it all at one go, but it'd be we certainly heard that was a load off her mind when we took that out. It was the size of my fist, and she's done well. She's done well. Again, the subgrouping of medulloblastoma is key for these patients. If they're group 3 or 4, they're pretty much goosed. If they're group 2, 1 or 2, they can usually do okay. But we'll see how they go on. Again, the key aspects, the technical aspects for these patients is, good working relationship with your anesthetist, a good working relationship with your navigation software people, with your intraoperative monitoring people, and just don't turn your shunt up to 8. That's what I'd recommend if you want to stay out of the courts. Thank you very much indeed for listening to me waffle on about tumor surgery here. I hope someday to join you all in person.
Thank you, John, for your excellent talk. It was a reminder of how tough and complex pediatric neurosurgery, and especially pediatric oncologic surgeries. So we have had excellent talks from Dr. Shahid, Dr. Nelson, and Dr. Osama. So the session is now open for any questions.
There don't seem to be any questions from the audience at the moment. People are probably thinking about it. But I would like to have make one comment, and that is from the last talk from Dr. John Caird. Over the last 30 years, having done a fair number of pediatric brain tumors, his talk is a reminder of the technical difficulties and the let's say the emotional trauma that we may go through while treating these tumors, and the angst as well. And finally, of course, many times whatever we do turns out to be wrong. Obviously, as he mentioned, the teamwork is extremely important, and we're very thankful for him for reminding us of all that. I have a question for Dr. Nelson. That's about the stereotactic radiosurgery. One of his slides mentioned meningiomas as being malignant tumors. Obviously, there's some meningiomas that are extremely malignant and do recur, and then locally as well as causing us great difficulty. I wonder why he mentioned meningiomas in the malignant category, or is just simply a subset.
To me, they kind of span the malignant benign, because you can kind of get just depending on the grading and the risk factors. So at our center, we still don't treat them with SRS, but that's I know there's a couple clinical trials that have been tossed around in Canada that look like they're going to try and address that and see if that's an effective method of either treating them primarily or treating the tumor bed afterwards, which we sometimes do adjuvantly to reduce the risk of recurrence, because that would hopefully cut down on the toxicity from the treatment, which is a really big concern, especially for younger patients.
Thank you, Dr. Leon. What we tend to do here is, having had access to radiosurgery, both the gamma knife as well as the cyber knife, and now, of course, linear accelerator-based radiosurgery here at Khanum, is that we tend to avoid complications of opening up venous sinuses by treating invasive sinus tumors with leaving a small residual behind, carrying out a grade 2 resection, and treating the residual with radiosurgery if and when they start regrowing. So that's something that we tend to do. Treating, as you mentioned, treating meningiomas primarily with radiosurgery. We tend to leave that for patients who have increasing size of meningiomas, which is, of course, obviously symptomatic, and the patients refuse to have open surgery. So that's what we tend to reserve that for.
Thank you very much. My question is for Dr. Shahid, and it's to do with the grade 2, histological grade 2 astrocytomas, which are IDH wild type. So we know that they behave like grade 4 GVMs. So is there a difference in the initial management for these patients, or should we treat them as high-grade tumors? Okay, thank you. I think he's not online at the moment. Thank you very much. No, I don't have any questions for Dr. Sama. Certainly, we have been doing endoscopic pituitary surgeries and have been really very cautious not to run into complications. So our scope of surgery is quite critically appraised and then patients selected for the procedure. And the aim is not to run into any CSF leaks, meningitis, and complications with the skull-based defects. So certainly, thank you very much, Dr. Sama, for bringing us up to speed with the learning curve, and then disenchantment with the procedure, which initially appears very glamorous, and then certainly another learning curve of how to come out of complications and prevent them. Thank you very much.
Thank you again for the invitation.
Thank you, Dr. Khan. I have just one last comment. Unfortunately, because of the proliferation of the internet and Sister Google, we have a lot of patients who come to us with a primary desire to have endoscopic surgery, whereas many of the tumors that we see are going right up into the third ventricle, going laterally, and honestly speaking, they would much rather be done or should be done through a transcranial approach. And again, it's to a great extent the desire of the patient to have a transsphenoidal surgery done or transnasal surgery done, and they tend to be refused at our center because we're fairly conservative in what we do, but then tend to go to other centers where they have the initial endoscopic procedure, and then finally go on to have a second transcranial procedure. So I think that at least insofar as we are concerned, we're fairly conservative. I would agree with you certainly about the olfactory groove meningiomas and the CSF leaks, because I've always been very skeptical of exposing the patients, of these patients, to a much larger incidence of CSF leaks and a residual as well. Whereas the tuberculum sellae meningiomas are certainly ideal for a transsphenoidal approach. That's really the basis of what we do here. Thank you. Thank you very much.
You guys do your endoscopic approaches with ENT, is that correct? Or are you guys doing microscopic transphenol?
Well, I've been doing it with the ENT colleagues.
And do you guys routinely get a nasal septal flap ready, or is it just a salvage in case there is CSF leak?
We haven't been very successful with them because they fall short. Maybe it's the technique. So I think that's something that we need to work on.
Sounds good.
Thank you very much. So just last few words before we wrap up the session. Special thanks to all the speakers. And I would also like to thank Don Caird, with whom I had the opportunity of working in Belfast and Dublin, because he's up in the very early hours of the morning as well. And our colleagues from Canada and USA have been up in the later evening hours of the Sunday or Saturday evening, in fact. So thank you all. And we have had a great session, quite a few learning points, more so in pediatric neurosurgery, where there are several pitfalls involving the child's health and secondary also with their families who are really involved in the patient management. Thank you all.